Thank you for joining us today at the American Heart Association's Arrhythmia, Heart Rhythms, Risks, and Resources educational webinar featuring Dr. Robert Grove and brought to you by Banner Aetna. My name is Corinne Kleinschmidt, and I am the Vice President of Community Impact for the American Heart Association Greater Phoenix. And we're very excited to bring this digital experience to you via Zoom today. Before we get started, there's a couple of housekeeping things to take care of. First, if you didn't notice when you joined on, we are recording this session, so it'll be available afterwards. So you're welcome to take notes, but if you do miss something, you will receive a link to this recording afterwards, so you will have access to the information. Also, there are live captions available if you would like that. You can see that at the bottom of the screen where it talks about live transcript if you want to be able to see captions. And another tip to help you see the session better today is you can change the view as whether you see a speaker or the slides or next to each other. In the top right corner of your Zoom screen, it says view, and you can select one of the options there. So try a couple of them and see what you like best. So now let's make sure you can ask questions. So we're going to be using the chat feature here today. So if you want to, click on the chat box. That will pull it up and give you a separate window, or you can move it around if it's in the way on your screen. And so we can look at everyone when you are using the chat feature, or you can select an individual person if there's a friend you can see on there joining the session today. But when you do ask a question, please select everyone. That way, myself and the other moderators for this will be able to see the question and be able to keep track. So let us test that chat feature. True or false, the term arrhythmia refers to any change from the normal sequence of electrical impulses for the heart. So pull up your chat, type true, false. Oh, Dr. Groves, I don't think we were able to trick them at all. It's 100% true. Everyone's getting it correct. That's perfect. What a great way to start the webinar today. Electrical impulses.
Great way to start.
Can happen too fast or too slow or erratic. And that's why we're going to learn more about them today, because we want to make sure we learn about how the heart should be pumping properly. As we get started, I do want to give a special thanks to our sponsor, Banner Aetna, for making this event possible. We're really excited to work with them to provide this information about arrhythmia. Banner Aetna is the Arizona's health insurance company that leverages the strengths of two of the largest healthcare organizations in Arizona, Banner Health and Aetna. So thank you very much, Banner Aetna, for your support. And I would like to welcome our presenter today, Dr. Robert Grove, who is the Executive Vice President and Chief Medical Officer for Banner Aetna. In his current role, Dr. Groves is responsible for population health management. He received his MD from the Medical College of Georgia and previously served as the Chief Medical Officer for Banner Health Now. And he's going to share his expertise with us today. And I'm really excited to hear about this. Dr. Groves.
Thank you, Corinne. I'm excited to discuss this topic. It's a complex topic, and I was just reflecting on the fact that over my career, there have been so many advances in arrhythmia detection and management that there's a whole new specialty, electrophysiologists or cardiologists that have additional training in arrhythmia. So it has gotten much more sophisticated just over the course of my career. So let's dive right in. What is an arrhythmia? Well, this is one of those words that all of us have heard many times, probably, and it simply is a deviation from the normal rhythm of the heart, that lub-dub that we're all familiar with. So today we're going to talk about what is a normal heartbeat, what is an arrhythmia, what are the types of arrhythmias, what kinds of symptoms should I be looking out for if I suspect that I might have something like this, and what treatment options are available for me? How do we get to a diagnosis, and who is at risk? And are there things about that risk that I can control? Just as we do with all of these sessions, we want to give you information that helps you address your health and makes it less likely that you'll run into this. And if you do run into this, you'll know what to do. So what is a normal heartbeat? Well, a normal heartbeat actually happens about 100,000 times and pumps about 2 million gallons of blood through the body on the average day. So that's an impressive amount of work that this pump that we are all familiar with to some extent does for us. In a 70-year-old, that translates to about 2.5 billion heartbeats. Pretty amazing statistic. Now, how does the heart function? This is I used to draw a simple diagram for patients when I was describing this to them that had 4 boxes in it. And the top 2 boxes were smaller, and those are represented here as the left atrium and the right atrium. You can see about 2 down on the left and the right. And those are what I call the priming pumps. Those are the pumps that take blood in from either the body or from the lungs, and then get that blood ready to be pumped again by preparing the lower chambers, which are usually the workhorses of this. So as you follow the arrows there, and I'm going to take you up to the top left-hand side, that's called the superior vena cava. It's the major vein in the body that collects all of the blood from your toes and fingers and tips of your nose, etc. All of that blood, once oxygen has been extracted and the waste product of CO2 has been put back into it, that comes down into that right atrium. And if you'll watch there, it goes through the tricuspid valve. And those valves function as one-way valves. In other words, you see the blood can go only one direction. So when the pump squeezes, when the lower pump squeezes, that valve is going to close very, very quickly. And you'll see then, if you'll follow the blood up through that blue chamber, it goes through something called the pulmonic valve. And that pumps it into the pulmonary artery. Now, interestingly enough, when you talk about the circulation of the lungs, the red and blue is reversed. And the reason that the major vessels are usually depicted that way is we think about, well, arteries are red and veins are blue because arteries have oxygen in them, and that makes the blood very red. And when it comes back, it doesn't have oxygen in it, and so it makes it blue. But in the lungs, the function of the lungs is to actually take care of that waste product, breathe out CO2, and to put oxygen back into the blood. So the artery, the inbound, is going to be blue in this situation. And then the pulmonary vein, you'll see after it goes through the lungs on the left-hand side of your diagram, is where that oxygenated blood is dumped back into the left atrium. And that'll be over there on the right side of your diagram. And now maybe you're understanding why I used to draw a simple diagram with just 4 boxes. But the same process repeats on the left-hand side. The blood that has just been freshly oxygenated dumps into that top priming chamber. It goes through the one-way valve called the mitral valve. And then from there, the left heart pumps it out through the aorta, through the aortic valve. And that's the start of distributing that well-oxygenated, free of waste blood to the rest of your body. And the cycle repeats. That's what the heart does. So sometimes people forget about the fact that the heart is also pumping blood through the lungs in an almost separate circulatory system. And that's where that oxygenation and waste reduction takes place, if you will. Now, the left side of the heart tends to be much more powerful. Why is that? It has to pump blood throughout the entirety of the body, whereas the right side only has to get it through the lungs. So that's a quick overview of what the function of a 4-chamber mammalian heart looks like. Now, when we talk about arrhythmias, you'll notice that the heartbeat has a rhythm to it, right? And it's the lub-dub. And it is critically important that that is a coordinated effort, and it is highly choreographed so that there's a node called the sinus node that initiates a beat, and that's transferred to the upper chambers. The upper chambers contract immediately before the lower chambers contract. So the priming pumps act, they fill up the lower chambers, and then the lower chambers act. And that sequence of events is highly choreographed. If the rhythm is too fast to allow that to happen effectively, too slow to allow that to happen effectively, or it's so erratic that there's no coordination between that top and lower chamber. That's what we refer to as an arrhythmia. In other words, a rhythm that is not working well to do the function of the heart. Now, all of us have had the sensation, or most of us have had the sensation. We like to say in common terminology, my heart skipped a beat. Well, an arrhythmia can be completely harmless, particularly if it is short-lived. If it doesn't last long, then it's not going to interfere with the overall function of the heart. And all of us from time to time may have our heart skip a beat, or it'll run fast for a second. And in kids, you can see this even with breathing. They have a huge variation in their heart rate. Their heart's very sensitive to that. And so when they exhale, it slows down. When they breathe in, it speeds up. And those are normal rhythms, in fact. Some are so brief that it just doesn't make a difference. But if it's persistent or it's severe, then it can make a difference very, very quickly. And the end story here is that the heart is unable to perform its function. And the place that that's often first recognized is your brain. And that's why people pass out when they have a sustained dysfunctional arrhythmia. Go ahead. Are all arrhythmias the same? You know the answer to this question, and it's going to pop up here in just a second. The answer is no. Of course they're not. Common names that you may have heard before: atrial fibrillation is when there is just it's almost as if that top priming pump just looks like it's writhing. It's not a coordinated contraction of the muscles. And so it doesn't do a great job as a priming pump of getting the right amount of blood into the big chamber, the ventricle, for pumping through the rest of the body. And that's why atrial fibrillation is a problem. Bradycardia simply means that the heartbeat is too slow. It's not going fast enough to keep up with waste production. It's not going fast enough to keep up with oxygenation requirements. And so again, if it's severe enough, then passing out is typically what happens. There are conduction disorders. There is an electrical system, and the system has to function in sequence very, very specifically. If you get a block in one of those limbs to the right or the left ventricle, that can cause a conduction disorder. If the original pacemaker of the heart is not functioning properly, that can cause an arrhythmia. Premature contractions are just like it sounds. There has to be a rest period between beats so that the heart can fill again. And you can understand that if it's premature, then the heart hasn't had time to fill completely. So a single premature contraction, not a big deal. But if it continues to happen again, you get dysfunction of the heart. It's not able to perform its pump function, and often the patient will pass out. Tachycardias simply mean fast rhythms, and they come in a variety of flavors. The one that we worry about the most is ventricular fibrillation. Now, you've heard of atrial fibrillation. That one is not immediately fatal. It is a problem that can be managed, and there are lots of strategies to do just that. Is associated with some risks that we'll talk about. But ventricular fibrillation, if that bottom main pump starts to have that writhing, like as some have described it, as it looks like a bag of worms. Instead of a coordinated contraction, it's just writhing in the chest. That immediately shuts down the ability to circulate blood throughout the body. And those are the events where you see people getting shocked, et cetera. That is a very dangerous arrhythmia that has to be treated immediately, or it will lead to death. Now let's go to the next slide. And there are lots of variations on the themes that we've talked about. It's an electrical system, and it can dysfunction in many ways. Adams-Stokes disease is a difficulty with getting the signal from the sinoatrial node or the sinus node through to the atria. And in Adams-Stokes disease, folks will pass out if they don't get that through well enough. Atrial flutter is sort of a variation on this theme, but in atrial flutter, it is a coordinated contraction of the atrium, but it's just going so fast that it doesn't have time to fill properly. And so you have a decreased ability of the heart to pump volume and function normally. Sick sinus syndrome is just like it sounds. That sinus node, the pacemaker, the lead drummer, if you will, the one that sets the beat, the rhythm for the rest of the heart. If that node starts to dysfunction either rapidly or slowly, you get what's called sick sinus syndrome. Sinus arrhythmia is anything that originates from that original pacemaker, if you will. And then there are some interesting problems. Wolff-Parkinson-White syndrome is the one that's most well known, but this is what's called an accessory pathway. So in other words, when you're transmitting that electrical signal from the upper chamber to the lower chamber, it goes in a very coordinated, prescribed way. And there is a specific speed at which it is conducted, if you will. Sometimes a workaround, a side channel develops from the top chamber to the lower chamber. And if the signal starts to go through that chamber, it'll often get to the chamber before the normal signal does and be reflected back. And you get a circular pattern of this electrical discharge that makes the heart go very, very fast. And that's can be what's called a Wolff-Parkinson-White syndrome. So as you can see, there are lots of complexities to this electrical system, and it can dysfunction in many, many ways. It's remarkable how reliable that system is in the vast majority of us over time. Next slide. Arrhythmia disorders in children, yes, they can happen in children. Let's talk about one more concept. You'll see it on the top there as long QT syndrome. And in a long QT syndrome, if you look at the tracing of a normal EKG, after the large ventricle has contracted, there's a time when everything, let's just call it resets, and that's called the T wave. The difference between where the ventricle is contracting, the Q wave, and you'll see that on the electrical signal on the EKG, and the T wave, that little tiny slope at the very end, the distance between those is called the QT interval. Now, if that gets very, very long, then you run the risk of the next signal happening on top of the T wave, on top of that reset, and that can trigger a significant arrhythmia. So a long QT syndrome can be inherited, can also be caused by some drugs, and those drugs often lead to a well, not often, but can lead to a ventricular arrhythmia that can be deadly. And so long QT syndrome is something that we have to look for and make sure that our patients aren't getting into trouble on specific medications. And as I mentioned, it can also be an inherited problem in children. Tachycardias can happen in kids. They can be normal tachycardias because they have exaggerated response just to breathing. But tachycardias of various kinds can happen in kids. Premature contractions can happen, as can ventricular tachycardia, though it's rare in kids. Supraventricular tachycardias, bradycardias, sick sinus syndrome, Wolff-Parkinson-White, and complete heart block can all occur in kids. They're just not as common as they are in adults. Now, what we haven't talked about yet is that there are certain substances that can contribute to an abnormal or irregular heartbeat, including, and this is your question. So let's see how everybody does on this one.
All right, what substances? We've got the
darn
options.
near 100%.
Oh, I was gonna say, I think they figured us out.
Excellent, excellent. That's right. And those of us who have lived a few years and perhaps gone out on a Friday night and God forbid overdone it, we'll notice this, right? It does lead to those brief arrhythmias that we've all heard about, but it can be particularly for someone who happens to have a long QT syndrome, or maybe they've got other reasons that they're at risk or vulnerable. Alcohol and tobacco, certain cold medicines, those that have Sudafed or phenylephrine in them, even antihistamines in some folks, can make it more common for arrhythmias to occur. And then there are drugs of abuse that can contribute to this as well. You all know probably the street names for those: cocaine, speed. Those types of medications can be problematic for folks that are predisposed to arrhythmia. Lack of sleep can increase your risk as well. Let's see if what we've got next here, Corinne. So bradycardia, here's the slow heart rate. So you look at a normal tracing up above, somewhere between 60 and 100 is where the normal heart rate is. And in certain highly trained athletes or runners, it can be below 60 and still be normal. But for the most part, between 60 and 100. When it starts to go much slower than that, then that's called bradycardia. And all bradycardia means is a slow heartbeat. So what would that feel like? Well, you might be fatigued or dizzy. Confusion can happen, and fainting or near fainting, something that in the medical profession is called syncope, S-Y-N-C-O-P-E, which is just another word for fainting. It can cause shortness of breath or shortness of breath when exercising. And in extreme cases, it can lead to cardiac arrest. And tachycardia is the flip side of that. So you can see that the normal heart rate there is around 60 to 120. And then tachycardia means it's going faster than normal. Now, not everybody will have symptoms with a sinus tachycardia. In other words, it's originating in the right place. It's just going fast. But if it goes fast enough, or if it's an irregular rhythm, then again, syncope can be the result. Lightheadedness, dizziness, the feeling of a rapid heartbeat that's often called palpitations, that fluttering feeling in the upper abdomen or the chest. May have a bounding pulse, may feel chest pressure, tightness or pain, may have shortness of breath, fatigue, and in severe cases, certainly unconsciousness, and again, cardiac arrest can occur. Let's talk about AFib for a second. Now, the other thing I want to point out is that this is different from a heart attack, what we commonly call a myocardial infarction in healthcare, or a heart attack in general parlance. And if the symptoms differ significantly for the most part, chest pressure, pain associated with shortness of breath, often sweating, it can be in the arm or the jaw, and is often associated with feelings of something's not right, or feelings of impending doom. It's even been described. You have symptoms like those, it's time to call 911 immediately. Don't mess around with it. If you're wrong, great. But if you're right, you want to make sure you act as quickly as possible. Symptoms of arrhythmia tend to be a little bit more general as those I've described. You might feel a fluttering sensation in your chest, but overall it's going to be fatigue, shortness of breath, dizziness, weakness, and passing out that you have. With atrial fibrillation, there are lots of folks who walk around with atrial fibrillation. And remember, this is when the upper chamber is just sort of writhing, incoherently. It's not marching to the right beat, not listening to the drummer, if you will. And some people don't notice it, and particularly younger folks without a lot of other chronic symptoms may not notice that they have AFib. However, symptoms are typical of arrhythmia, the ones that we've just been talking about. That feeling of fluttering in your chest, the shortness of breath, weakness, confusion, faintness, fatigue, and occasionally there can be chest pain or pressure. If it includes that, then it's still time to call 911. If you have these other symptoms, it's time to get checked out to see what's going on, to make sure that there's not something that you need to be worried about. All right, on the next slide. And we just talked about this. And again, if you think you're having a heart attack, don't delay it. other areas of the upper body is pretty inclusive. And occasionally, folks may just have the shortness of breath, but it's not wheezing typically. It is a sensation of I cannot get enough air or I can't get enough oxygen. And very often it's associated when it starts being advanced with a cold sweat, may have nausea or lightheadedness. Those are the things that you need to call 911 about. Don't mess around and guess about what it might be. Just get help and we'll figure it out from there. What about stroke? Well, we talked about this in one of our sessions earlier, maybe last year even, the fast mnemonic and face drooping, arm weakness, difficulty with speech, slurred speech specifically, and the T is for time to call 911. So that's another area where you don't want to mess around. If you have face drooping, numbness, or, and the way you can test this is if it's in a loved one, or you look in the mirror and smile. If one side doesn't move, that's an indication. If maybe you can raise both your arms, but if one of them starts to drift without intention, that's another sign that something very sinister is going on and you need to get help quickly. Now, how are arrhythmias diagnosed? And this is an area where there's been quite a bit of advancement. When I first started training in healthcare, the Holter monitor, or telemetry, a unit on the hospital where everybody is on a heart rhythm monitor 24/7. The Holter monitor is the outpatient version of that. It's a device that usually it has it's a pretty big device that you wear around your neck with leads, just like an EKG, attached to certain areas of the heart. And usually that's put on you for about 24 hours and then taken back to the physician and they review it. Often it will be with a diary, so you can mark down symptoms if you're having any and what time they occurred, so they can match those symptoms to the tracing that they see on the Holter monitor. Now, the problem with the Holter monitor is the same problem I have when I take my car in because it's been doing something. It seems like invariably it doesn't do it while you're looking. And so Holter monitors can miss very infrequent arrhythmias. In fact, they historically have often missed infrequent arrhythmias. The other strategy is an event recorder. Now, this is different in that what an event recorder does is only record the tracing when there is an event. And so that's another way to get at the specific arrhythmia. You can wear that one for longer and it will capture events. Then there's treadmill testing, which is just like it sounds. It's when they hook you up to an EKG, may hook you up to other stuff and put you on a treadmill and then start walking you faster and faster and see how your heart responds. A tilt table test is an interesting one, and that one is also just like it sounds. They literally will put you on a tilt table or on a table that tilts and see how your body responds to a significant change in posture. There's a normal response and then there's an abnormal response, and that's what they're looking for. Electrophysiologic testing is, this is that new specialty that I talked about, where cardiologists typically are trained very specifically to look at and manage the electrical system of the heart. And they've gotten very sophisticated, and there are ways to test that, often in the cath lab, where they will stimulate certain areas of the heart and notice what happens when they do. You can also do esophageal electrophysiologic procedures. And the reason that you would do that is because the esophagus passes right behind the heart on its way down to the stomach. And so you can insert instruments right behind the heart and sometimes get more sophisticated readings of what's going on there than you can outside the chest. And then, of course, there's the echocardiogram, which really is looking at heart function in the face of or without arrhythmia. And that really is just a sonogram like you use to look at a woman's belly if she's pregnant. It's the same technology, but it looks at the ability of the heart to squeeze, the integrity of the valves, et cetera, to get an idea of structural heart abnormalities. This is the Holter monitor. As I said, it's a big thing that hangs around your neck. The leads are connected up there, and usually it's about 24 hours. They describe it here as a movie, and that's essentially what it is. The EKG obviously is only looking at a few seconds of your heart rhythm. This will look at 24 hours of your heart rhythm, much with a tracing much like an EKG. And there's the event recorder, a little bit easier to manage, and there are other ways to get an event recorder, but it's looking at the electrical system and then trying to identify events and then recording that so that it can be transmitted to the doc. Cardiac stress test. This is the treadmill test that we talked about earlier, also referred to as a cardiac stress test. It's not complicated. They'll hook you up to an EKG and we'll take some baseline vitals to know what's going on. They start you walking, and then you go faster and faster and faster until you've reached maximum exercise where they see something on the EKG tracing that suggests they should terminate the test. And then you'll gradually slow down from that and recover. And the whole time that you're doing this, of course, an EKG is being recorded, and you can see changes in the configuration of the normal electrical pathway called an EKG, right? You can see changes in that are typical of ischemia, in other words, threatened heart attack. You can also see people go into arrhythmias that are stimulated by exercise. And so that's another way of looking at it. And during recovery, there can be some abnormalities that can inform the physician in terms of what they're dealing with and how to address it. Here's the tilt table, and just as I described, it is changing your posture rapidly is what they're doing. They will often have you hooked up to a pulse ox, a blood pressure machine, and an EKG. And then literally what they do is shift the table until you're standing. And then they monitor your vital signs for 10 to 60 minutes and see how your body responds to that change in posture. The normal response is to keep your blood pressure up and adjust the rhythm so that you can continue circulation throughout the body. There are a variety of abnormal responses, and one of those is passing out, and it may be because of bradycardia or other arrhythmias, but the tilt table test, it essentially is evaluating your individual response to standing up rapidly from a seated or lying down position. And then, of course, we talked a little bit about electrophysiologic testing. That's often performed in the cath lab, where they give you a little local anesthetic and thread a tube into your heart. And they go right into the arteries of the heart. They use a fluoroscope, which is a real-time X-ray machine. It looks like an X-ray that's a movie. And they can see exactly where those electrodes are through that process. And then when they get them positioned, they can both record and map the path of electrical impulses during the heartbeat in a much more sophisticated way than you can with an EKG. And they can also stimulate certain areas to see if they can provoke an arrhythmia. And of course, if they do, you're in the right place for treating that arrhythmia because you've got the cardiologist who is an expert at your side. Now, with the esophageal procedure, we talked about that before, a thin catheter inserted through the nose and positioned in the esophagus, right behind the heart. And they can perform more sophisticated, sometimes electrophysiologic testing from that site. So don't be surprised if they want to put something in your esophagus to look at your heart, I guess is the moral there. And then, of course, there's the echocardiogram. As I suggested, this is a sonogram of the heart, essentially. And so those sound waves are bounced off the heart and used to assess its structural integrity and its function. Now, who is at risk for arrhythmias? Well, if you have heart disease of any kind, That increases the risk of arrhythmias. The risk of arrhythmias increases with age, particularly atrial fibrillation. Then there are congenital conditions, many of them that may predispose to arrhythmia. There are chemical agents, and then there are other factors. We talked a little bit about how lack of sleep on a chronic basis can increase the risk for arrhythmia. So stress as a general category can increase the risk for arrhythmias. Okay, this is the important part. What can I do? What are the controllable risk factors? What can I do about it? Well, one of the things you can do is find out if you have and treat high blood pressure, get that into the normal range. Controlling cholesterol reduces the chances that you're going to develop atherosclerosis, which is that disease that leads to heart attack because it affects the blood vessels feeding your heart. Guess what? Those same blood vessels also feed your electrical system. Losing excess weight will help. It takes strain off of the heart, and there are other factors associated with obesity that increase the risk of arrhythmias. Eating a good diet so that you're not eating a lot of junk food or foods that put you at risk for heart disease and metabolic syndrome. Obviously, stopping smoking, we know that very, very clear. And to the extent that you can, avoid secondhand smoke. Regular physical activity is also something that reduces your risk. Now, there is, it's often referred to as a curve. And so there is a right amount of physical activity to do. Extreme athletes, ultra marathoners and so forth, actually begin to increase their risk of arrhythmia at some point. And so exercise is great, and even vigorous exercise is great. But some of the ultra marathoners and over-the-top exercise strategies can increase the risk again for arrhythmia. If you drink alcohol in moderation. What is that? Well, for the most part, for men, it's a couple of drinks a day. For women, it's about one. Sorry about that, but that's what the current recommendations are. And it doesn't mean that on occasion you can't have a couple of drinks, but as a regular practice, much more than a drink or two a day will increase your risk for a whole host of things, including arrhythmia. And the WHO, we've talked about a little bit. If you have heart disease, underlying lung disease, and that can be multifactorial. Some of the meds that we use to treat underlying lung disease can also have an impact, particularly on tachyarrhythmias or fast heartbeats. Previous heart attack obviously increases the risk. Heart surgery, high blood pressure we talked about, diabetes, sleep apnea because it interferes with normal sleep is a risk factor as well. And then cigarettes and coffee and all of those other drugs that we talked about earlier. Family history is important. There are some genetic predispositions that we haven't well defined, but it does tend to run in families to some extent. And then alcohol use, as we discussed previously. Now, we're going to talk about people with no symptoms with a brief video that I want to play for you now.
Patients come to me all the time and they have palpitations. They feel the heart beating. Most of these people, actually, it's their own rate going fast at times. And it's what I call the princess in the pea syndrome. Some people feel everything, and you can put as many mattresses as you want on top of that pea, and they still feel it. And that's very unfortunate. Whereas other people can be in almost life-threatening rhythms, and they don't feel anything. So the sensation of an arrhythmia is very difficult to pinpoint, even for a doctor. You need proof. So if you're having a feeling of palpitations, it's a very simple way to figure it out. We just give you a monitor to wear for a given period of time, and we correlate your symptoms with the electrocardiographic representation. You can even use phone apps now to do it. And if your symptoms turn out to be atrial fibrillation, then we have to go down that path. This is not to be disparaging to any doctor who listens for 15 seconds on a patient's chest that they haven't figured it out. It's just like an ECG. An ECG is 12 to 15 seconds of your life. So you come and tell me I have palpitations. We do an electrocardiogram. I listen to you. I don't hear anything abnormal. I don't see anything. So for maybe 30 seconds of your life, I've evaluated you. That's totally inappropriate to make a decision. I need to correlate your symptom with the electrocardiogram. So no, if your doctor doesn't have the either desire or the knowledge to take it to the next step, you should probably see a cardiologist or an electrophysiologist. They're going to give you a monitor and they're going to at least make the correlation. You need documentation of the cause of your palpitations. It might be atrial fibrillation. It might be your own rhythm. It might simply be premature beats. The important thing is you need a diagnosis. It's easy to get, and there's no reason why someone shouldn't do it for you. The more difficult problem is people who may be at risk for atrial fib, who have no symptoms, but still are at risk for a stroke if they get it. And that's a very difficult group of folks that I'm approaching now in a little different way. So if I think somebody has a high stroke risk and they have a number of things about their medical history that suggest they're at a relatively high risk for atrial fibrillation, I've even done some very long-term monitoring in those people. So if you have symptoms, it's straightforward. Put a monitor on, figure it out, and see where you're going. If you have no symptoms, but let's say you've had relatives who've had AFib, you've had somebody who's had a stroke, and you're just concerned, well, what if I'm next? And how am I going to figure that out? Then I think, depending on how high your risks are for a stroke, we can have that discussion.
All right, here's our next quiz question. What's the reason why arrhythmias matter? You guys got this down now.
I was going to say all of the above. Good job, everybody.
All of the above. Yep, true statement. By the way, I wanted to make a brief comment before we go to resources about stroke and AFib. You might wonder why atrial fibrillation is associated with stroke. And what we believe happens is when that atrium is contracting like a bag of worms instead of a coordinated contraction, it allows blood to pool. And pooled blood is more likely to clot. So quite literally what happens is clots may form in the atrium. They're more likely to form on the low pressure, in the small, they are more likely to form in the atrium because that's where the source of the problem is. And once that clot forms, it can get loose and go through the normal circulation through the aortic valve. And that clot, if it winds up in your head, is going to cause a stroke if it's large enough. And so that's the risk. And so that's why you'll see folks that are in atrial fibrillation or have intermittent atrial fibrillation will also be on, will often be on blood thinners. And it's a risk benefit equation that has to be calculated for each individual, but the intent there is to reduce the risk of clots forming in the atrium in AFib so that they don't have the opportunity to go downstream and lodge in the brain. And that's the relationship between atrial fibrillation and stroke. And as the doctor mentioned, there are folks who don't notice that they're in atrial fibrillation. And I think it's going to be less common for those undiagnosed atrial fib patients, because as he mentioned, there are phone apps now, and everybody's working on this arrhythmia detection strategy. And so I think people are becoming more attuned to that, but don't try to self-diagnose if you're having symptoms. If you're having symptoms, see your doc, explain what the problems are, and get the right diagnostic test so they can pinpoint it for you and give you the best chance of living a long and healthy life. Now I'm going to turn it back over to you, Corinne, for resources and questions.
As you see on this slide here, there are 3 different links we have from the Heart Association with more information about arrhythmias, as well as our support network, which is available for heart disease and stroke survivors and their caregivers. But there's a small group in that also that's specifically around arrhythmia and AFib. And then we also have more information about recipes and healthy things that you can eat to have a healthy diet. Thank you, Dr. Groves. Really appreciate your time and sharing this information. And on behalf of the AHA and Banner Aetna, I hope you found this information helpful. We do have time for questions, and we have a lot of questions. So I will get started with the first question that had come in, because we have Dr. Groves here as our expert to help us. So first question is heart valve regurgitation related to arrhythmia?
Is heart valve vegetation related to arrhythmia?
Regurgitation.
Oh, regurgitation. It can be, and it depends on the cause of the regurgitation. And what that means simply is that instead of functioning normally as a one-way valve, the valve has become leaky. And so when the more muscular lower chamber contracts, for example, blood goes back up into the atrium instead of going downstream because the valve doesn't function properly. Now, it turns out that a lot of the electrical system is located around those valves. And so if the reason for the valve dysfunction is structurally related to where that rhythm center is, then yes, they can be related.
Are conduction disorders dangerous, and do they require treatment?
That's a tough question. Almost most of the time, significant conduction disorders in critical areas need to be treated. Now, why am I saying it that way? Well, there's something called right or left bundle branch block. And what that means is that one of the arms of that electrical system that comes down, from the upper chambers, it's delivering that message to the ventricles. If the right bundle is slowed down, the right heart contraction will be slightly delayed, and vice versa for the left. Those typically are not life-threatening, and typically you don't need to do anything about those types of abnormalities, but they are markers for increased risk for other types of arrhythmias and heart disease. And so it's not that you don't pay attention to them, of course you do, but those don't need to be specifically treated. And then block can be a term. If it's complete heart block, you betcha. I mean, that has to be treated with a pacemaker. If it is a delay, then sometimes you can watch it for a while, like in sick sinus syndrome. Sometimes you'll be able to follow along and say, okay, well, it's not severe enough to need treatment yet. But in every case, a block in the electrical system is important and needs to be investigated so that there's an understanding of what the problem is, whether it's likely to get worse, and whether or not it needs to be treated.
I was gonna say, like the other doctor in the video had talked about it, but it's really important to know why so you can watch it and know what to do. Can drug use years ago permanently affect your heart rate and cause arrhythmias?
Interesting question. It depends on if there, some forms of drug abuse can lead to damage to the heart. In fact, IV drug users, those who inject drugs, can end up with something called endocarditis. And endocarditis is an infection of the inside chambers of the heart. Usually it hangs on the valves. You can actually have what are called vegetations on the valves, which are collections of bacteria that are growing there. Fungus can do that as well. And in that case, if there's been actual damage to the valve or the perivalvular area, then yes, it can lead to some chronic problems. I think for the most part, if there has not been direct damage to the heart, that things can get back to normal over time. Now, having said that, there are a lot of variables here, a lot of unknowns. And in many cases, we don't know all of the effects long-term of drugs of abuse. And it depends on when they were used in the development. And, there are so many factors there, it's going to be hard to give you a specific answer, but the answer is it can.
Are there differences in symptoms between men and women when it comes to AFib and arrhythmias?
That's an interesting question. I am not personally familiar, maybe Corinne is, I'm not personally familiar with studies of that. We know this for heart attack, that yes, symptoms can differ between men and women. And in fact, women tend to have non-classic symptoms. Now, when I say non-classic, it's because most of the studies were done on men. And so that became the standard. And women may not have as much, crushing substernal chest pain. They may feel it as a jaw ache or just generalized anxiety, discomfort in the chest. I mean, it can be highly variable. With arrhythmias, I don't know the answer to that question. It would not shock me if there were differences. I just don't know.
Okay, I hadn't heard of differences for that specifically, but it goes back to, again, heart attack and stroke warning signs. Yes, there are, but I think the example of it depends on the person, regardless of your gender, is that, some people are more sensitive than others.
Yeah, and people vary a lot in terms of their sensitivity to AFib, as you heard on the video. I mean, it can be from I don't feel anything to I feel it and it's not there.
Yeah.
It can be that variable.
Could too high a dose of metoprolol and olmesartan cause an AFib episode?
Run that by me again.
Metoprolol and olmesartan.
Metoprolol and
Sorry.
I'm sorry. Yeah. No. It's a
those
challenge
cause
for everybody these
AFib
days.
episode?
Yeah. Can too high a dose cause what? I'm sorry.
Cause an AFib episode?
I can imagine mechanisms whereby that might be true. I think it's less likely that those types of drugs would cause that than stimulants. In other words, what metoprolol is a beta blocker. It tends to slow the heart rate. And I think valsartan was the other one that you mentioned.
Yeah, olmesartan.
Yeah. That's unlikely to do that as well. But that, I can conceive of ways that might happen. For example, if you have a supraventricular arrhythmia that is suppressed when in normal heart rate, because it doesn't have time to do reentry, but you slow it down enough so that it has time to do reentry, conceivably that can happen, yes.
Someone had shared that they can hear their heart pumps in their ear when they're lying down or when they do exercise, and are concerned, is that a problem?
No, not, particularly if it's, if it feels rhythmic, if you will. I used to worry when I was in medical school. Of course, I had every disease imaginable when I was in medical school, but I used to worry about the same thing when I was in medical school. And they were talking about aortic aneurysms, and if you touch your supraventricular notch, that little notch right there at the top, and you can feel your heart there, and it was like, okay, that's normal. It is normal. And many people can feel their heart, and many people can feel it thumping in their chest after exercise and so forth. That alone is not a cause for concern.
If you're already on blood thinners, does that decrease your risk of stroke?
The short answer is yes, for clots. For that type of stroke, it may slightly increase your risk of bleeding, as you might imagine, or hemorrhagic stroke. And that's the balancing act that we have to strike when somebody has atrial fibrillation. By the way, it's not trivial. It's 5 times more likely that you're going to have a stroke if you have AFib. And so we want to, decrease that if we can. The balance is that blood thinners increase the risk of bleeding. And that can be hemorrhagic stroke, or it can be in the gastrointestinal tract, et cetera. And so that's the balancing act that we try to strike. that risk-benefit ratio.
Does microvascular cardiac disease increase risk for MI and or AFib?
Yes, microvascular disease is usually what we think about with diabetes. Diabetes in particular tends to lead to microvascular disease early on before, it doesn't mean it excludes macrovascular disease because that's present too, but it is the typical way that metabolic diseases like that progresses through microvascular disease. All that means is that it's the very small blood vessels that are affected first. But like any blood vessel, if you affect enough of them, blood flow to that organ is insufficient. And so, yes, it can increase the risk for both.
Is there a blood thinner that is better to use when you have AFib compared to others?
Yeah, that's a complex question as well. And there are so many out there on the market now. And that is a discussion best had with somebody who knows your history, who knows what medicines you're already on, and who understands what those risks are in you specifically. So the answer is there is likely a best option for you, but it's impossible for me to know what that is without having the full history.
If we have time for one more question, and this one I'm asking because I myself was very curious as well. So caffeine increases your risk. How much caffeine? Am I okay still having my morning coffee?
Yeah, the morning coffee is probably not a risk factor. As you know, there have been so many studies that coffee's good, coffee's bad, off and on over the years. I take a pretty pragmatic approach to that. Maybe it's because I love coffee. But my pragmatic approach is if it's not causing you the jitters, and we all know where our limits are on that, then you're probably not dramatically increasing your risk for arrhythmia. There are exceptions. If you're already prone to arrhythmia, if you're sensitive to caffeine, then yeah, those things can make a big difference. But I'm not suggesting you should avoid coffee if you don't have a history of arrhythmia, mainly because it would be too painful for me to imagine that. But the data doesn't show that normal, 1 or 2 cups in the morning is going to make a big difference.
Excellent. Well, I feel better already. So thank you so much.
Yes.
And thank you everyone for your questions today. And thank you so much for taking the time to answer them, Dr. Groves. We've really enjoyed learning about arrhythmia and heart rhythms, the risks, resources, and information on how to reduce our own risk. Thank you, Banner Aetna, for helping support us so that we could have this education session. Tomorrow, everyone on the call here, you're going to receive an email with a link to the recording of this session, a PDF of this presentation, but then also a link to a feedback survey. So please take the time to fill out that survey. It helps us to know what you learned, but then also gives us some feedback on how we did, and so we can make our next session even better. And of course, speaking back to the caffeine part, some lucky survey completers will win a $5 Starbucks gift card. So I guess that was my other point too, is like, hopefully I'm not giving out a reward that's going to.
Oh my goodness. I didn't realize where that question was coming from. Thank you.
I know it leads directly there. So, but yes, but a small coffee, it will be just fine.
That's right.
So thank you, everyone. Have a great afternoon.